MedDRA coding. My name is Dr. Samina Qureshi. I'm an international medical officer with the MSSO. So I'm based here in Maryland and will be your instructor for today's webinar. Joining me will be my MSSO colleague, Hannah Eaton, who you just heard a few minutes ago. She's going to help facilitate today's webinar. Now, in order to be interactive, we will be using the Poll Everywhere software, and this is going to allow you to participate in some of the coding exercises that we're going to do together. Now, the instructions to join are in the chat section of your GoToMeeting control panel, and throughout the presentation, at various points, I am going to prompt you to log in and join Poll EV so you can participate as well. Now, before we do that, I will, on the slides, show you the QR code in order to help you and facilitate joining Poll EV. Now, one additional point I want to mention is towards the end of this presentation, we have a dedicated Q&A period, but that Q&A period is intended to answer questions just about the various coding principles that we discussed today, and it's not intended for general coding questions or other topics. And so before we start, just for you to know, this session is scheduled for 2 hours. But of course, depending on the volume and the number of Q&A we have, we may finish a bit earlier. I will also be demonstrating various functions in the MedDRA web-based browser. And for that, in order for you to follow along and use the MedDRA web-based browser for the coding exercises, we have provided a temporary training ID and password for you to use. And this is available for you in the chat section of the GoToMeeting control panel. Okay, so before we begin, and in case you are joining for the very first time in one of our MSSO MedDRA webinars, I always like to begin with having a few basic introductory points and providing a general framework on the background of MedDRA. So MedDRA is an ICH initiative, and the ICH stands for the International Council for Harmonization. MedDRA was developed around the mid-1990s, and it's an living, breathing, and it's an ever-evolving terminology which requires maintenance. So the ICH tasked the MSSO, or the MedDRA Support Services Organization, the job to maintain and support MedDRA. Now, this includes providing trainings such as the one you're having today, as well as it includes administering the MedDRA licenses. All of these MSSO activities are overseen by the ICH's MedDRA Management Committee, and the MedDRA Management Committee is composed of various industry as well as regulatory bodies across the ICH regions. And the WHO also serves as an observer. So this just sort of gives you a sort of a background understanding of how MedDRA evolved. And for those of you who have attended our many training webinars, we always are required to go over this disclaimer and copyright notice. And I'll just sort of try to paraphrase it as best as I can. The first bullet basically talks about the fact that MedDRA is owned by the ICH, and all of the material presented today is also copyrighted material and owned by the ICH. Now, aside from the logos that you see, all of the material presented today can be used by you in your organization, but if you in any way change or modify the the material in any way, you must acknowledge that those changes are in no way supported by the ICH, but your own. And the second bullet is legal lingo, so I'll just read it as such. This presentation is provided as is, without warranty of any kind. In no event shall the ICH or the authors of the original presentation be liable for any claim, damages, or other liability arising from the use of the presentation. And the third bullet is not relevant for us today because we're not using any third-party material in our presentation. So let's begin the actual presentation. So before we begin in the minutia of the presentation, it's good to get an overall overview of what the course is intending to cover, or what we will cover. First of all, we're going to discuss some of the more advanced principles in the MedDRA term selection PTC, or points to consider document. Some of you who have attended our MedDRA coding basics class are familiar with this document, where we also discuss some of the principles. We're going to look at what are various MedDRA concept descriptions, how to find them from the website, from the browser as well. And then, of course, there will be several examples of how to properly code using some of the advanced principles outlined in the MedDRA PTC document. Of course, we're also going to have the ability to use Poll EV, right? You're going to be able to go work along with me with the many MedDRA exercises. And of course, I'll show you how to use the MedDRA browser. And today I'll be using the MedDRA web-based browser. And towards the end, we'll summarize for you some of the coding wisdom tips, or the coding pearls, as we like to call them, that you should use as you code and perform more and more advanced coding exercises. And of course, like I said before, we have a dedicated section at the end where we'll allow for you to ask me questions that you have on any of the coding exercises that we went over today. Okay, so let's start with, I would request everyone, either if you're using your internet browser on your laptop or you're using your cell phone, to go to pollev.com. And once you go to pollev.com, enter as username what's in red on this slide, SAMINAQURESH185. So use that as the username, and you'll be able to join me as I perform my exercises. After putting the username, click join, and on the next page you don't need to do anything, just hit skip, and that'll take you to the activity. Now, for those of you who are using your smartphone, here's an even easier way to join Poll EV. Just use this QR code, show it to your smartphone camera, and it'll take you directly to that previous screen that I showed you. So let's give everyone a few minutes just so that you can, log in. We'll practice logging into Poll EV. I'd like everyone to please log into Poll EV. Okay. And then if you're logged in, this is what you should see. Our very first exercise. Okay, so hopefully everyone's entered. The first question in Poll EV, if you have successfully logged in, is, have you already attended a MedDRA Coding Basics webinar? So let's see what my audience is saying. Okay, so some of you have already logged in, are answering and responding, and as I can see, 61% of you are, yes, you did attend our MedDRA Coding Basics webinar. 33%, or a third of you, are saying no. 8% of you are saying no, but you are very experienced. So some of the things we learn will be applicable to you. Okay, so I think this is a good mix. This is everyone will learn regardless of which category you fit in. You will definitely learn some good principles on coding today. Okay, so I will show the QR code again before our next Poll EV question. So if you were successfully able to log in now, excellent. Any questions in the chat panel? Anyone having trouble joining? Hannah, are there any questions from the audience?
I'm not seeing any questions yet.
Okay, wonderful. Okay, so let's go back. Okay, so we are going to basically now look at the document that I described or mentioned, the MedDRA term selection points to consider document. And here is the cover page, or the first page of this document. Basically, this is one of many in our suite of PTC documents. This is specifically the one on MedDRA term selection. And what does this do? What is the primary aim of this document? It basically provides you a term selection or coding advice, right? For both industry as well as regulators, because as we know, both industry and regulators use MedDRA. And the objective is to provide you a framework of principles so that everyone accurately and consistently codes, right? So they establish both a preferred option on various coding scenarios, as well as an alternate option on how to code various scenarios that you encounter in coding. And of course, this document is to be used to provide you a framework or a basis for creating your own organization's internal coding guidelines or coding conventions. Okay. So basically, you should look through it, and as we do our exercises, I'll refer to various principles in the coding in this PTC document on what's the preferred approach, as well as what is the alternate approach. Now, this document is released every complex version release of MedDRA or the 0.0 version release. This document was developed by a working group, as I mentioned at the very beginning, by the ICH, or the International Council on Harmonization's Management Committee. It's updated annually every March 1st. As I said, it coincides with the complex MedDRA version release, which is also on March 1st. Complete versions of the documents are available in these languages that are listed: English, Japanese, Chinese, Korean, Spanish, and Russian. For all of the other languages in which MedDRA is translated, you have a condensed version of this document. Now, where can you find this? This is available on our MedDRA website, as well as you can access it from the MedDRA browser. And you can also find it at the JMO website, which stands for the Japanese Maintenance Organization. Okay, let me just demonstrate for you how to find this PTC document. If you go to the website, under the how to, so the website is www.meddra.org. On one of these tabs, you go to how to use, and in the drop down, you have support documentation, and it takes you right here. Can you hear me, Hannah?
Yes.
I was having some volume issues. Okay, so from the website, you go to meddra.org, and very neatly and very conveniently, we have a tab under the support documentation, which is specifically for all of our PTC documents. And under that, the one we're discussing today is the MedDRA term selection points to consider document. And of course, you have the others, the MedDRA data retrieval and presentation PTC document. You have the MedDRA PTC document, which is also the companion document. Okay, so now we know how to get to that from the website. Now, from the MedDRA browser, the web-based browser, when you open the browser and you log in, also another way to get to the documents is you see all of these blue tabs at the top. One is dedicated solely for MedDRA documentation. When you click on that, it automatically takes you to where we were before, which is our website. Okay, so that's how you get to the PTC document. Okay. Now, here's we're going to go through and show you what are some of the principles or what are some of the scenarios that the term selection document addresses or discusses. It goes through a variety of very, it's a very comprehensive list. And you can see right here, some of the things that it discusses are how to approach diagnoses and provisional diagnoses, how to approach death and other patient outcomes, suicide, age versus event specificity, how do you address congenital terms, how do you address neoplasms. So as you can see, it has a wide variety of topics that it addresses and provides guidance. And here you have a continuation of the list. It talks about medication errors, how do you address device terms, social circumstances, medical and social history, and so forth. Now, let's talk a little bit, let's get into the actual substance of coding. What are some of the general principles that you should always remember? Now, when you start to code, your aim should be to always select the LLT or the lowest level term that is current, obviously, right? There are some LLTs in the MedDRA browser in the terminology that have been marked non-current. So don't use those for coding, only use those which are current. Okay, and of course, the primary aim is for you to select the LLT that most accurately, we're going to sort of emphasize this point over and over throughout our exercises. You have to pick the LLT that most accurately reflects what has been reported in your verbatim. So let's take an example right here. In the parentheses, you see an example of a reported verbatim. For example, if you had the term abscess on face, this is what you have, the information on your report. How would you code that? You wouldn't simply select abscess, right? Because you have to choose the LLT term that most accurately reflects the reported verbatim information. And as you know, abscess can be anywhere. It can be on your neck, it can be in the brain, it can be in the lungs, it can be on the skin. The one here, specifically, it's giving us information. It's not just an abscess, it's telling you where it is. So when we would go in the browser, or we would look at all the terms in MedDRA that have abscess in them, we would try to pick the one that most closely or most accurately reflects the term. So we would pick not just abscess, but we would pick facial abscess, right? Because that information is given to us. Again, the point that we also want to remind you is don't use non-current LLTs, right? They still show in the browser and because they're legacy terms. Okay, and let me just demonstrate for that for you in MedDRA browser of what non-current LLTs look like. So if we look at the term abscess, you will see that there's just the plain term abscess is there, but there are also 386 specific terms with different abscesses. Abscess bacterial, abdominal, breast, gum, hand, but of course we chose the one that was most relevant to us or very specific, or facial abscess, right? And if I highlight the PT where facial abscess resides and I right click and I go to browser, I'm going to just wanting to show you an example of a non-current LLT. So among this list of LLTs under this PT, we have one that has a red box around it and the LLT is in red font. So anytime in the browser you see a red box around an LLT, that LLT is non-current and you should not use that for your coding. Okay, so that's what a non-current LLT is. It still shows for historical and legacy purposes, just to show you that at one point in time, this was a good LLT. You could use it, but it has been marked non-current now, not to be used for coding. Okay. So I hope the take-home message has been delivered, that do not use non-current LLTs and use very specific terms if they are available, depending on what's reported to you. Okay, so sometimes there are scenarios where you will have to select more than one LLT term to represent what's been reported. Because if you use only one term, you won't be capturing everything very specifically of what's been reported. Now, one drawback of that is that using more than one term, more than one LLT to cover a verbatim event can lead to redundant counts. Okay, therefore you must document in your internal coding conventions that at times you are sometimes using more than one LLT in order to comprehensively capture a reported term. So let's look at an example of that. If you had a verbatim term of metastatic gingival cancer, if you were to only code gingival cancer, you would miss the portion of the concept that it's a metastatic carcinoma, right? If you want to very accurately, remember we have to capture everything very accurately. The best way to do that would be to capture both the site, gingival cancer, as well as the fact that it's a metastatic carcinoma. So the most appropriate way to code this reported verbatim term would be with these two LLT. So the MedDRA term selection points to consider document also addresses that. Now, another thing we want to also mention and keep in mind as we perform coding, some of the good coding wisdom is always check, especially if you are a relatively newer coder, check the hierarchy of a particular LLT you choose. Like for example, look under which PT that LLT is linked, which HLT, which HLDT, as well as SOC. That way it'll confirm that the LLT term you're choosing is in fact what you want it to represent. Okay? So for example, you want to code low energy. In your verbatim string, you were given the report that said low energy. But in MedDRA, there is no exact match LLT with that. So you search and search and you decide, well, the closest thing that I can use for low energy is the LLT worn out. Then you would check the hierarchy of which PT is worn out linked to make sure that you're going on the right track in your thought process. You check and you see that the LLT worn out is linked under or resides under the PT fatigue. And actually, that's what you mean to say. So you're confirming that that is the correct choice of the LLT you chose. So the way to sort of confirm that you're going around the right route of that concept is to check the hierarchy. Okay. Now, we also mentioned at the very beginning that we are going to review what are concept descriptions. Now, we've highlighted the second bullet that don't think of concept descriptions as definitions. They're not defining a particular concept term, but more it's just a description, exactly what the name implies. It's a description of how that particular concept is used within the context of MedDRA. Okay, and because MedDRA is a global terminology, sometimes in translation, the actual intent of the meaning is somewhat, diluted or mistaken for something else. That's why for some of the key principles, some terms or some concepts have concept descriptions so that everyone understands them uniformly. Okay, and of course you can access these in the MSSO browsers, and let me show you that where concept descriptions reside. So here we are logged into our MedDRA web-based browser. Again, at the very top, you have various blue panels. And the very first panel, as you look at the browser, is labeled MedDRA Concept Description. So I'll click on that. And here you see all of the terms that do have concept descriptions reside here. And you have an alphabetical listing at the top. So here for example, we have a concept description for abuse. And here you're saying, for the purposes of term selection and analysis of MedDRA, this is how it is to be taken. Abuse is to be used in the context of MedDRA. And as I scroll down, the alphabetical list goes on to sort of have a MedDRA concept description, some various concept. We have a description for cancer and carcinoma. We have a description, what does chronic mean within the context of MedDRA? So lots of terms are in here. Of course, it's not all inclusive. It just has concept descriptions for some of the things that we feel need to be very uniform and may be misinterpreted in a global perspective. Okay, so those are concept descriptions. And here's a screenshot of what I just showed you, that in the MedDRA web-based browser, there's a blue click a box at the top dedicated to MedDRA concept descriptions. Okay, and here we're showing you that it's in alphabetical order. So if you are curious if a particular concept is defined, you can look at it alphabetically. Okay, do we have any questions thus far, Hannah?
No questions in the chat.
Okay, wonderful. Okay, so let's move forward. Now we're going to go and look at some of the various topics that the PTC document, or the points to consider term selection document, addresses. Here we are sort of guiding you on how to approach a single diagnosis. So if you have a definitive diagnosis, right? A definite diagnosis without signs and symptoms, it's very easy. Since you only have a diagnosis given, there's no associated sign and symptoms. The best thing to do, for example, they say myocardial infarction, you select the term myocardial infarction. okay? Because that's all you're given, a diagnosis. There's no signs and symptoms. On the other hand, if you have a provisional diagnosis without signs and symptoms, you treat it the same way. They only gave you a provisional diagnosis, nothing else. So a provisional diagnosis means that something has not been confirmed. And the clue to that is usually it'll be preceded by suspected, possible, or rule out, meaning we're not sure, but we think this is the most likely thing that the person has, but we're not really, it's not confirmed, right? And a definitive diagnosis is it's been confirmed. Here's what he has. This is the diagnosis. This is what the patient has. Now, as far as signs and symptoms are concerned, it's important to distinguish. Symptoms are more subjective complaints, right? They're offered by the patient, like, I feel dizzy. It's something the patient himself or the subject is experiencing. Signs, on the other hand, are objective findings, which the patient may not know about, but they're like something that you can measure, like a pulse rate or a BP reading, right? So symptoms are subjective, signs are objective. Okay. Now here's the scenario where you have a single diagnosis, but this time you have signs and symptoms with a single diagnosis. Okay. The preferred option, remember I said in the term selection document, the PTC, you have a preferred option as well as an alternate option. The preferred option on how to deal with a definitive diagnosis with signs and symptoms is to just do the diagnosis. Because it's confirmed, it's for sure, this is his diagnosis, and here are the signs and symptoms, you only need to code the diagnosis. So in the example, if they say the person has a diagnosis of anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm, those are all gold standard signs and symptoms of anaphylactic reaction, so you only need to code anaphylactic reaction. On the other hand, if you have a provisional diagnosis with signs and symptoms, the preferred option that the PTC document tells you is to code the provisional diagnosis along with the signs and symptoms. So here you have an example. If you see the clue is there, possible. When you say possible, it means it's a provisional diagnosis. It may be a myocardial infarction with the following signs and symptoms: chest pain, dyspnea, diaphoresis. So in that case, since it's a provisional diagnosis with many signs and symptoms, the preferred option is to choose the provisional diagnosis and code all the signs and symptoms. Okay, so let's continue. Now, we gave you the preferred option, right? And I told you for every preferred option, there's also an alternative. The alternative to a single diagnosis with signs and symptoms is, okay, you can do the diagnosis as well as the signs and symptoms. And here is the example. You have a diagnosis with all the signs and symptoms. So the alternate option is to do and code both of them. Now, the alternate option for provisional diagnosis is only do the signs and symptoms. So in the example of the possible myocardial infarction with all the signs and symptoms, the alternate option is to forget about coding the provisional diagnosis, but just capture actually what was experienced: the chest pain, the dyspnea, and diaphoresis. And of course, depending on the nature of your data that you collect, the nature of the types of analysis you do, you can choose to either do the preferred option, which was on the previous slide, or the alternate option. Okay. Now, always include, remember I said the gold standard? For example, you have a diagnosis and you have a whole list of signs and symptoms. You have to code the sign and symptom that is not typically a gold standard sign and symptom of the diagnosis. For example, you have a report of a diagnosis of myocardial infarction. You have chest pain, dyspnea, diaphoresis, EC changes, and jaundice, right? So if you take the preferred option, which was just to code the diagnosis and not the associated gold standard signs and symptoms of that diagnosis, then the correct way would be to code myocardial infarction. And don't forget to code jaundice, because that's not one of the typical gold standard sign and symptoms of myocardial infarction, whereas the others are, right? So again, in parentheses, we make a note of that typically jaundice is not associated with myocardial infarction. Therefore, we would code that particular symptom or sign and symptom. Okay. So again, the take-home message is always include sign and symptoms that are not gold standard signs and symptoms of that particular diagnosis. Okay, so now we're going to look at an additional point. How do you code conflicting or ambiguous, unclear information? The first, of course, attempt, or the first thing you would do, is try to query and get more specific information. But if you're unable to do so, you can't query or you can't just get any additional information. And in the first example, if you have a report of hyperkalemia, right? It's a diagnosis of hyperkalemia with a serum potassium of 1.6, right? Now, it's important to have a reference range of typical lab reference ranges, because you may not be able to memorize the more common ones. But if you look at the standard laboratory ranges, you know that potassium typically ranges from a normal of 3.5 to 5.5 milliequivalents. So hyper means more. So the report is hyperkalemia, which means increased potassium, but the lab value that they're giving you with it is low from the the reference ranges. So that's conflicting. How can he have a hyperkalemia with a lab that's showing low potassium? So in that scenario, when you have conflicting information or unclear information, you're not able to get any additional information with a query. The preferred option or the advice is to code the term serum potassium abnormal. And why do we do that? Because serum potassium abnormal covers both of the reported concepts. The part where the lab value is low and the part where it's saying high, hyperkalemia. So in order not to code either high or not to code low, you just say abnormal. Very important thing to remember. This is going to be tested in our upcoming coding exercises, so keep that point in mind. Here's another example, GU pain of conflicting or ambiguous information. What does GU mean? Well, if I'm a specialist that usually deals with, I'm a nephrologist or a urologist, I would say, of course, it's common sense. That means genitourinary. If I'm a gastroenterologist, I'll say, of course not. That typically probably means a gastric ulcer. So we can't assume, right? GU can mean different things to different people. Therefore, if I can't query and I can't get additional information, the best bet would be to code with pain. I know it's pain. I don't know which system they mean, but I do know there's some pain, right? So the baseline thing is pain. So I cannot clarify or get queried additional information what GU means. So the best bet is to do pain. Okay. So let's go on to additional scenarios. Here, again, we always, the very first step is we try to get more information, right? Now, if we cannot, then what do we do? So if you have a report that says turned green, okay, what would I code that? Well, some people may go and choose something nail is green. You can't assume, never assume, because what turned green? We don't know if the pill turned green. We don't know if the person's skin turned green. We don't know if his toenail turned green. We don't know what it was. Was it a product? Was it the person? Therefore, it's very vague or ambiguous. So we would say unevaluable event. There's some sort of event going on, right? And it's an event, but we can't evaluate it. We don't know what it is totally. On the other hand, if you have a report of patient had a medical problem of unclear type, Here it's somewhat, a little bit more clue that we know it's a person at least. It's not a pill or a bottle or a liquid. It's a patient. The patient or the person had a medical problem of unclear type. So this is a bit more narrower, this LLT. It's an ill-defined disorder because we know it's in a person, but we don't know what happened. He has some sort of disorder. Okay, so distinguish between the two. This is very broad. We don't even know if it's a person or a product related thing. Here, at least we know it's a person, so it's a disorder. It's an ill-defined disorder. Okay, so moving on along to more things that are ambiguous or unclear. Here you will have a verbatim, for example, of clinical complication of IUD. Now, again, as I said before, for different people, it can mean different things. IUD complication. What does it mean, right? Is it something complication associated with device? Intrauterine death, does it mean fetal death? What is it? So when you have IUD and you really can't really tell what it is, you can do unevaluable event. Okay. In the second bullet, we have hypoglycemia, and this is similar to what I showed you before. Hypoglycemia, right? It means low glucose. But the lab value in parentheses is saying blood glucose equals 200 milligrams per DL. Now, if you're familiar with your standard lab values, you know that a normal fasting blood glucose typically ranges from 70 to 99, right? This one, on the other hand, is way above the standard normal blood glucose, which is 200. But how can you say hypo, low, when we know the normal is around 90, 70 to 90? So again, this is conflicting information. And if you remember, when you have that scenario, the best bet is to choose the corresponding abnormal term, blood glucose abnormal. Okay. And of course, for the first one, we do unevaluable event, because just to show you that IUD could mean intrauterine death, or it could mean something related to a device, right? So if you don't have any clear information, like we showed one of the previous slides, it's unevaluable event. And for this one, we choose the corresponding abnormal term. Okay. Now, always remember also, I've seen this in coding when we've done other coding classes, where sometimes people confuse medical conditions with the similar corresponding investigation result. They can't, they don't make a distinction between a condition versus an investigation result. Now, a condition, hypoglycemia is a condition. Of course, you have an investigation associated with it with a decreased glucose, but hypoglycemia reported as such is a condition, and you can verify that. Like I said, you can clarify if you have any confusion by looking at how the particular term is linked in MedDRA, right? The LLT hypoglycemia is linked to the SOC metabolism and nutrition disorders. So you know it's a condition. Whereas the decreased glucose is a lab finding. You did a test, a blood sugar test, and you have a decreased glucose. That is a lab test. It's an investigation finding, and that's further confirmed when we look at the MedDRA browser and look and see the hierarchy of the LLT. It's linked to the SOC investigations. All lab investigation results and findings will be linked to the SOC investigations, whereas disease conditions will be linked to the various corresponding disorder SOC. Do we have any questions thus far?
I am seeing 3 questions in the chat at the moment.
Okay.
Our first one asks, for defining concepts that are not in the concept descriptions, is there a medical dictionary that you recommend users reference?
Well, typically we cannot, condone or pick one dictionary over another. But for our purposes, typically we refer to the Dorland's Medical Dictionary. So it's an excellent question, and that's what we typically refer to, the Dorland's Medical Dictionary. But you're free to use any established and well-referenced dictionary.
Wonderful. Our next question asks, how can I find out if a symptom is gold standard for a particular diagnosis or not?
You can certainly look up, I mean, in any of the medical references, such as we typically use, you can use any established medical reference like the Merck manual. Look up that condition, for example, pancreatitis, right? Look up what are the typical findings, signs, and symptoms. Research and find out, if you don't already know, what are the typical standard, gold standard, established signs and symptoms for a particular condition. And the third question?
Wonderful. And our last question at the moment asks if you could provide some guidance on how to approach the verbatim reduced GCS score.
Okay, well, like I said, this is for answering coding questions that we are doing, in the exercises themselves, because then it takes the conversation off the topic. So let's save that towards the end if we have time, but the instructions are to keep your questions focused on the relevant examples that we're discussing today. So let's save that if we have time towards the end at the Q&A. Okay, so let's move forward. Okay, we did this one about medical condition versus investigation result. Okay, so here's the one, ambiguous investigation result. Here we're seeing a glucose, and it has, a value, a glucose 40 mg per dl. The person selected glucose low. And it's unambiguous, meaning it's clear because it's telling you it's 40 milligram per DL. You pick glucose low. Glucose is clearly below the reference range. So that's good, right? Because it is low, because the normal range, like I said before, is about 70 to 100. And 40 is definitely low. Now, here's something that's ambiguous. The first one is a good one. It's unambiguous. The second one is ambiguous when they're just saying his glucose was 40. Now, 40, it doesn't give you units, right? 40 what? You can't assume that the typical standard investigation is assumed. You can't assume which unit it is and say, oh, of course he means mg per dl. We don't know that, right? Because as you know, in Europe, typically they use millimoles per liter. So in that case, that would be not right. So don't assume which units should be there. If a investigation finding or result does not have units, the coding advice is to use the abnormal term, right? You can't say low, as in the first example. In the first example, we could say low because it had units. So if no units have been reported, select the corresponding abnormal term. Okay, so this is also important, and we're going to have coding exercises, so keep this in mind. Okay. Now, investigation results that are consistent with a particular diagnosis, right? We touched upon this a little bit before. So if they say elevated potassium, right, and then they give you the lab value of potassium of 7.0 millimoles per liter and hyperkalemia, right? The person selected hyperkalemia because because you're going to have to again look at your reference range, your standard lab reference ranges. And I know that a normal potassium is somewhere between 3.5 to 5.5 millimoles per liter. And this one is above 5.5, the standard, 7, so it's accurate. It isn't elevated. And the diagnosis of hyperkalemia, of course, in hyperkalemia, you will have that finding. So I can safely select hyperkalemia, right? Because that's the diagnosis. And the potassium increased is an investigation finding. And remember in the beginning, if you have a diagnosis with associated labs or signs and symptoms, you only need to code the diagnosis, which we've done here with hyperkalemia. Now, what about a group? You have a whole string of investigation results. For example, if you have increased alkaline phosphatase, you have increased SGPT, you also have a report of increased SGOT, and you have an elevated LDH, right? You have a whole list of various lab results. Well, what should you do? You have to code each one individually. right? Find the corresponding code, like the SGPT increased, SGOT increased, LDH increased, and the alkaline phosphatase increased. Why? Because they're all reported as individual lab results. There's no diagnosis there or even provisional diagnosis there. In that case, just select 4 individual terms. Now, if you're physicians, typically physicians are guilty of this. They'll see these labs and say, of course, these are abnormal liver function tests. I mean, it doesn't take a rocket scientist to figure that out, but you cannot make that assumption. Nowhere does it say that, right? You're probably right. He probably has his whole, all of his liver, these are all liver function tests. They're abnormal, they're increased. We can't select one term for that. It's not reported as such. You can only code what has been reported. So you would take each individual investigation result and code it with 4 codes. Okay, so take off your physician hat. Don't diagnose when the diagnosis is not provided. Okay. Now here we're going to again show you various verbatims and go through them and see which ones are correct and which ones are not. For the string, testing showed increased serum creatinine and BUN with increased BUN/creatinine ratio. So of these 4 LLTs listed, let me see, what would I do? I don't see any diagnosis, right, where I could take my preferred option and just code the diagnosis if these were the associated gold standard finding. So I would go and code increased serum creatinine. I would code the BUN increased, which is also there. I don't think I could code renal function test abnormal because they didn't show that in my verbatim. So so we're going to come to that. The first 3 are correct. We cannot say renal function test because it's not in there. So we would take each lab finding and code them separately. Now for the next one, patient had features of aldosterone excess. Okay, and you have 3 LLTs to choose from. You have aldosterone increased, you have aldosteronism, and you have blood aldosterone abnormal. So features of aldosterone excess. These are features or characteristics of aldosterone excess, and that in itself is a sort of a diagnosis term, right? So from the 3, the 2 are lab findings, which of course would be found in this diagnosis, but there's one that matches what's purported. Aldosteronism is a synonym of aldosterone excess. Okay. So here we move on to the principle of combination coding, right? When one condition is more specific than the other. For example, if you reported arrhythmia due to atrial fibrillation. So I'm thinking, well, what do I code? Do I code arrhythmia or do I code atrial fibrillation? Okay, one is more specific. As you know, atrial fibrillation is a type of arrhythmia. So yes, it's an arrhythmia, and they're telling you what type. It's an atrial fibrillation. So therefore, you would choose the more specific or clear term, atrial fibrillation. And you don't lose information because that is a type of arrhythmia. If you were to code arrhythmia, you would lose the information that what type of arrhythmia, specific atrial fibrillation. In the second example, they give you a very broad description. It's a hepatic function disorder. In parentheses, they tell you acute hepatitis. So we're both looking at both conditions. They're giving you 2 conditions, but one is more specific. So you take the one with more information or which is more specific. In this case, it would be acute hepatitis, which is a type of hepatic function disorder. So why not take the most specific one when it's provided to you? Okay. So take the more specific term when you're giving 2 terms and one is broader than the other. In the second principle, they tell you to choose a MedDRA combination term when one is available. Okay, so in your first verbatim string, you have retinopathy due to diabetes. Now, some of you who are less experienced, you would say, okay, I will capture one term that reflects retinopathy, and then I'll capture the diabetes as a separate term. Of course, you would do that if in MedDRA there was not a combination term that has both. And lo and behold, we do have a term as such. We have a LLT diabetic retinopathy. So the best solution to code would be to use a term that has both of those concepts and not unnecessarily split, since you have that option available. Okay, and the second one, similarly, it's a rash with itching. Some of you will say, well, I have to report both. I don't want to lose information. Let me just code rash, and separately, let me code itching. But the prudent thing would be to look for a term, hopefully that has both things in one term, and we do have such, itchy rash. Right? So don't unnecessarily do two codes when you can find a term that has both things in one concept term. And you'd be surprised that a lot of terms that are in MedDRA that very precisely and concisely represent a concept. And look at this one, breast cancer. In parentheses, it tells you what type. It's a HER2 positive type of breast cancer. Okay, and in MedDRA, some of you are experts, some of you are less experienced, but when you do your search, you do find that there is one term, a LLT, HER2 positive breast cancer. Okay, so this gives you the breast cancer as well as the type in one term. So use a MedDRA combination term when one is available. And when one is not available, we already talked about what to do. In that case, use two terms. Okay, so all of these take-home messages are going to be utilized when we look at coding exercises later on in the presentation. Now again, if splitting provides more clinical information, select more than one term. In all cases of combination terms, of course, this is the underlying principle for anything when you do coding, is to apply your medical judgment. And again, to make sure that you're choosing the correct term, look at the hierarchy of that term. Where does it lie in the MedDRA hierarchy? Which SOC is it linked to? Which PT is it linked to? Right here in diarrhea and vomiting, very easy. There's no combination term for that. So you would choose two LLTs, one for the diarrhea, one for the vomiting. Again, wrist fracture due to fall. You would capture the wrist fracture. And of course, why it's important to capture fall. So we do have a term for fall. You would capture that as well. And here in the BRAF positive malignant melanoma, we don't have one term that has both things in there. So you would definitely have to capture that it's a malignant melanoma, but you have the type. It's a BRAF gene mutation type of malignant melanoma. So you would capture both. Okay, so again, if you're given the concept or the verbatim string of retinal disease from HIV with near total blindness, right and left. So we've been through a couple of sort of scenarios before this slide. We always try to choose a term, if we have it, with information in it in one term. So here he has retinal disease. Some of you will say, well, okay, let me just pick retinal damage or retinal disorder, right? That's one thing. Then you would capture just the HIV because it says he has HIV, retinal disease from the HIV with near total blindness. But wouldn't it be good if we have a term, and we do, that is HIV retinopathy? You wouldn't have to split it because there is a term. He has a retinopathy, which is a disease, HIV related, and with near total blindness. And we have a specific term that says blindness both eyes. So you'll be surprised at how granular MedDRA is, right? We have over, with this 29.0 release, which was just released 2 days ago, we have over 90,000 LLTs to choose from. So, you know, do a search, look in the appropriate, do a top-down search, look at the appropriate SOC, look at the particular HLG which you're looking, and you may find the specific term you're looking for. Okay. Now, again, we did show you what a concept description is, but just again, how do we define MedDRA concept description? Or what is the MedDRA concept description for medication errors? In MedDRA, you have lots and lots of terms on medication errors. And the MedDRA concept description for medication error reads as such. For the purposes of term selection and analysis of MedDRA coded data, medication errors are defined as any unintentional, right, and preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So it's very important to note that it's unintentional, therefore it's an error, and it could have been preventable, right? So that's the MedDRA concept description for medication errors in the context of MedDRA. And this is a very expanding and very important area, medication errors, both from a regulatory perspective as well as for industry. And we have dedicated webinars discussing the appropriate use of these various terms that come under medication errors. For those of you who come across these frequently or would like further clarity, I highly recommend attending and listening to these webinars that are dedicated to medication errors. Okay, again, I would like to say that the MedDRA term selection PTC document, section 3.15, addresses these. So for more detail, you can look at this, as well as the companion document has very detailed explanation. And of course, become familiar within MedDRA with the HLGT of all the terms that you have for medication errors and other product use errors and issues. So if you come across these scenarios frequently or your line of work deals with this more, these are the areas where you can get more detailed information and clarity. Okay. Again, we went over the terms, what the medication error, how it's described as a concept description. And of course, again, this is pointing you to the specific webinar, MedDRA Coding of Medication Errors. As well, in our learning management system, or LMS, there's a special module for that, and there's other videos if you look at our trainings we have on the MedDRA YouTube channel. Okay, so now let's move on to the overdose, toxicity, and poisoning aspects or concepts. For overdose and toxicity and poisoning, it's very important to remember that you cannot code using these three terms unless your report explicitly reports it as such. Okay? And when it is reported, do code them with any clinical consequences that are mentioned. For example, in the first verbatim string, they tell you stomach upset from study drug overdose. So here they explicitly say overdose. So then you are able to use and code with overdose. And then any consequence they report, which was stomach upset, you should also choose that as well. Okay. So how about in the second scenario when there's an overdose without clinical consequence? Well, the preferred option is to just code overdose because there's no reported clinical consequence, right? So in our verbatim, it said patient received an overdose of medicine without any adverse consequence. The alternate approach is you can also say no adverse effect, just to highlight that although they took an overdose, there was no AE. So you can do either. The preferred is not to do anything, but the alternate, if for your particular scenario or your data set, if you want to, you can also put no adverse effect. Okay. So very important three concepts: overdose, toxicity, and poisoning. Very important not to code these unless the report explicitly says so. Don't assume. Okay, here we have another example where we're saying unintentionally took more than the maximum recommended dose due to dispensing error. right? What am I able to code in this? Unintentionally took more than the maximum recommended dose due to dispensing error. Okay, the correct answers are, in this case, I can code accidental overdose because the MedDRA concept description for overdose is defined as such. Okay, so it's important. Overdose, let me show you how it's defined in the MedDRA concept description. Again, I went to my MedDRA web-based browser. At the very top, I open up my MedDRA concept descriptions. I go alphabetically to O because I want to see how is overdose defined. So for the purposes of term selection, overdose is more than the maximum recommended dose in quantity or concentration. Okay, so just because the MedDRA concept description defined overdose as such, that's the only reason I was able to use overdose when I coded. Let me go and find that. Okay. Because it's defined here, or not defined, it's described here as an overdose, and it matches my MedDRA concept description, I was able to choose the term accidental overdose. It's unintentional. When something is unintentional, it's accidental. So the correct coding for this particular verbatim string would be accidental overdose, as well as drug dispensing error. Okay. Now, other important concepts we want to address, and that are principles which is addressed in the PTC document, is how to approach death and other patient outcomes. So some of the other patient outcomes are death, disability, and hospitalization are considered outcomes. And typically they're not coded as adverse events, but more they're captured in the outcome field of the report. Now, if the only death is reported, if one of the outcomes, if only death is reported in the report, or only disability, or only hospitalization is reported, then you would code it if that's the only thing reported. Now, if also a death term in MedDRA adds some important clinical information, then in that scenario, you would also code it along with your other ARs, right? Adverse events. So in this verbatim string, we have patient experienced a rash and had sudden cardiac death. My first thought would be, well, death is already recorded in the outcome field. They already told me that death is considered an outcome, typically recorded in the outcome field. I don't need to touch that. But the third bullet tells us if the type of death or some descriptor of the death adds important clinical information, then you're allowed to code it. So in this case, it said it was a sudden cardiac death. I have a code for that, LLT. So I would code the rash as well as the sudden cardiac death because it adds clinical information. So do note this important point on how to treat these three outcome concepts: death, disability, and hospitalization. You only code them if they're the only thing reported in the report, or if you code them if they add any clinical information, such as the case of sudden cardiac death. So remember those as well for our upcoming exercises. Okay, so also we're going to touch upon drug interactions. Okay, drug interactions are sometimes when you have an interaction where you're taking a particular drug and it interacts with a certain food you eat, another drug you took, or a device and alcohol that you're using. Okay, so there's reactions or interactions can happen between different things. Now, if a reporter states in an interaction, select the term for the interaction term and any adverse event that's also reported. So let's look at our string here. The patient drank cranberry juice, which interacted with anticoagulant drug and caused an INR increase. So here we see that the juice is a type of food which interacted with the drug they were taking, so it's a food interaction. And then any adverse event that happened, the INR increased, so we also code that. So this is the appropriate way to code a drug interaction and any associated or reported AE. Okay, so if a reporter does not specifically state an interaction, if they don't say that, don't assume, oh, if it said patient drank juice, he took an anticoagulation, he was taking an anticoagulant and drug, his INR increased. Don't assume there was an interaction unless they say so. Okay. If the reporter does not specifically state an interaction, just code the medical event. And now we come to something a bit more dismal: suicide and self-harm. Okay, so we have several suicide terms. It's important to distinguish one from the other. Suicide attempts, you have completed suicide, you have self-harm. So when you have a report of that, be very careful and be very accurate, and you pick up the information that's only being reported. For example, don't assume that an overdose happened, even if it was intentional. Remember, you can only say overdose if it's explicitly reported. Okay, if self-harm report does not mention suicide or suicide attempt, only code the self-injury term, right? Don't assume, oh, he did so much self-harm, he was trying to commit suicide. Unless it says it was an attempted suicide, don't assume. And of course, if a suicide is fatal, someone did a suicide attempt and there was death, then you would code it as completed suicide. Otherwise, you would just say it's a suicide attempt. So important to distinguish the differences in that. Select a term that reflects the outcome instead of the attempt. So here, for example, suicide attempt resulted in death. You wouldn't say suicide attempt, right? Because it tells you the attempt resulted in death, so you choose the outcome. It was a completed suicide. Okay, so read the whole verbatim and deduce from there what actually happened and select the most appropriate code. Okay, so any questions before we go to this one?
We have one question that came in, and it asks, would you interpret like in a verbatim as a reported provisional diagnosis? For example, headache like a stroke, rash like a mosquito bite.
Well, depending on the context, it's a very good question. Depending on the context of the report, you have some terms in MedDRA that have the term like in them. So in certain scenarios, that's part of the LLT term. In certain scenarios, depending on the context of the report, it may mean that it's a provisional diagnosis. So yes, depending on the particular vignette or the verbatim string and the context of the report, it may mean either or. First of all, look for the exact LLT if it has like in it. Otherwise, you would choose use your medical judgment. Is it more describing a provisional diagnosis? Good question. Okay, so let's move on to this one. What would you select? Death from cerebral hemorrhage. Okay, so they're showing you death from cerebral hemorrhage. Again, remember we say typically death is an outcome. Disability is an outcome, hospitalization is an outcome, and they're typically captured in the outcome field, and you don't need to code them unless they provide additional clinical information. So in this case, it's not a type of death. It didn't say sudden death, right? And death, and it's just reported death. So the correct thing would be to code just the term cerebral hemorrhage. Right? Because death is going to be in the outcome field. You report what is the adverse event, the cerebral hemorrhage. Again, the underlying thing, first and foremost, is to use your medical judgment and the information as it is provided in the context in which it is provided. Okay, how about this one? Remember I told you different things about how to approach death? Patient was found dead. Remember we said if there was nothing else found in the report, nothing else is reported except death, then you do code death and you take exactly what's given to you and you code as close as possible to what's given in the verbatim string. So obviously Nowhere did it say that he died in his sleep. I don't know that. It's giving you a little bit more information than just death. Death from natural causes, I don't know. I wasn't there. We don't know. What is known and what is in the verbatim string is that he was found dead, and you would be surprised to know that we have an LLT for found dead. So as you become more and more, familiar with MedDRA Dictionary, you'll see what's there. But it's always a good idea to look in the browser and see all that's available. You never know, you may find an exact match when you didn't think there was one. Okay, so here, this lady looks very uncomfortable. After taking an antihistamine along with her prescription proton pump inhibitor, a 53-year-old woman developed vertigo. Okay, so we have this little scenario, this verbatim, she took an antihistamine along with her prescription proton pump inhibitor, and she developed vertigo. So what would be the correct thing, and what did we discuss a little while ago about drug interaction? Okay. Some of you may say, well, she took an antihistamine and she took a proton pump inhibitor, so I'm going to code drug interaction. And that would be incorrect, because nowhere in the string did it say. Maybe those are her normal 2 things that she takes every day, right? It didn't say there was an interaction. We can't assume interaction unless it explicitly says so. So the correct answer is what she experienced, which is vertigo. Okay. And now I would like you all to participate with me and perform some coding exercises. So if you have a smartphone, please use your camera to log into Poll EV. And in the chat panel, you will see what to use as the username, Samina Koresh 185. Okay, so let's all log in. And I'm going to go into my Poll EV as well. We already did the first question. This is what you should see. Let me present it, and let me go back. Exit. Let me activate it. Okay. Okay, so the verbatim string is deliberately took an overdose. And what would be remember the take-home message is to exact match of your primary aim is to do exact match of what is reported. So remember that principle. Try to take an exact match LLT to what is reported in your verbatim string. That's your first attempt. Of course, if you can't find it, then you go to using your medical judgment, you choose what it is. Okay, so our people are changing their mind as we talk. Okay, so let's walk through. And the correct answer is 84% of you, because it's intentional overdose is also correct because it's the same PT. But the exact match, 85% of you were very smart and did the deliberate overdose because it matches the reported verbatim. Although intentional overdose, 13% of you are correct as well because that's the PT, one and the same. But deliberate is an exact match. So excellent job, 85% of you. Very good. Okay. And of course, 3% of you said suicide attempt. Remember, we said for suicide, you can't assume it. Nowhere did it say there was a suicide attempt. So even if she took an overdose, jumped over the cliff, and whatever, you can't say suicide attempt unless it says so in there. Okay. So let's go to the third one. I'm going to activate it. Man with decreased fertility. What would be the best match for this? Okay. Man with decreased fertility. Okay, so I think we are having a very smart class, or I'm doing an excellent job teaching, or people are very, very already well versed with MedDRA principles. The majority of my class, 95%, got fertility decreased male correct. Perfect. It most closely matches what is being reported, right? And just for those of you who chose infertility, a decreased fertility doesn't mean you're absolutely infertile, right? Infertile means zero. They're totally infertile. A decreased fertility is a different concept than infertility. Okay, that's more absolute. And the male infertility, male, again, infertility is incorrect, so that's wrong. The fertility decreased 1%, you're right, but why not include the very important information that it's the guy, it's the male. So the male fertility decrease is the most accurate, complete answer. Excellent job, 95% of you. So if you have gender information, definitely put it in there, and we do have it here, and we have an LLT with that, so you would choose that. Okay, so let's go forward. The correct answer, of course, as we said, is fertility decreased male. So let's go to the next one. Here's our next exercise. Became colorblind in adolescence. Okay. Which one would I choose? And I want to do all of the information. Became colorblind in adolescence. And 82% of you are choosing color blindness acquired. Some of you, okay, so I'm happy to see that only distinction is, well, now we have 2% are saying color blindness. Okay, so why wouldn't I choose color blindness, and why are some 80% of people doing the acquired? Let's go to our browser, and I want you to see how when I say go to the browser to look at the hierarchy, why that's important. It helps me decide from that 1% who just chose color blindness. Although you're right, but why not color blindness alone? And why did 82% pick acquired? If you look at the hierarchy, just color blindness, when I look at the hierarchy, goes to the primary SOC, and I know it's primary because there's a blue box around it, congenital. So this color blindness, the plain term, is linked to the SOC congenital, which means the person is born with it. Whereas 82% of the people were very correct in choosing the acquired, because the acquired, he said he got it in adolescence. He wasn't born with it, which is the congenital link with the plain color blindness. He got it in adolescence when he was, older. And that is the correct one. That is not connected to the congenital SOC. Okay, so excellent job for those of you who chose the acquired. Okay, and now we come to the little spelling of color in the British way with the O-U-R and the American way without the U. Remember, this is just testing this very, very small point that try to be an exact match. And those 85% of people chose the color with the American spelling. Of course, both of these encoding would be 100% correct, right? But the take-home message to do an exact match, 85% of you were correct. Okay, so let's go to our next question. And I'm going to activate it. And here we have the verbatim. All they told us is turned very greasy. Okay, we touched upon that, remember? Turned very greasy. Okay, what turned very greasy? His nose, his hands, his hair, the bottle of pills, his pill became greasy. The device that he was using became greasy. What became greasy? In scenarios where it's very vague, where you don't know if it's the person, you don't know if it's a product, you have no idea what turned greasy. The frying pan he had breakfast in. No. So we don't know what turned greasy, right? So 88% of you are correct. When it's something is very broad, we use unevaluable event. right? Because it's an event, we don't know where it happened, or if it's a product or a person, and it's unevaluable. And remember we said ill-defined disorder was when it's a bit narrow and we know it's happened in a person, because a person can have a disorder. A thing, a product can't have a disorder. So that would be incorrect. Unevaluable event is the correct answer. So very good to 88% of you who picked that. Now for the 6% who picked reaction, again, that would most probably lead to something in a person. So I would still pick unevaluable event. And a reaction, infers it's between two things. And we don't know that. A reaction between a drug and a person, a reaction between a drug, something and a product. So that's still, unknown. The broadest term here is unevaluable event. Okay, and of course we don't know it's skin. For those of you who said 2% skin, it's not written in the report and we can't assume. Okay, so let's go on to another trick question. Our poll number 6. Let me activate that. So here we said the patient experienced a medical problem. Okay. Remember we had a similar slide before that when we said, the patient experienced something. Okay, so adverse event, for those of you who are saying adverse event, we do know it's an adverse event, but we know it's in a person, right? An adverse event can happen to anything. So the best code among the choices is ill-defined disorder. The adverse event is vague. It's not much information. We don't have information of the type. Is it a person or a product? Unevaluable event, unevaluable reaction. We do know there's a person. So the best thing, a person can get a disorder. So it's ill-defined disorder. And that is the correct answer. Okay, so let's move on to our 7th question. Let me activate it for you all. The 2-year-old accidentally took his mother's medication. And, like I said, some LLTs have lots of information and we're surprised. Which LLT among the ones here would be the correct choice? The 2-year-old accidentally took his mother's medication. And we always try to keep as close as possible to the reported verbatim. Okay, I am happy to see that at one point we had 90 people, 90% of the people chose the correct answer, which is accidental drug intake by child. Okay, the reason that's correct is because, first of all, it's accidental. We know it's a child. That's why the accidental exposure to product is wrong. It doesn't have child in there. And it's not really an exposure, right? Because exposure could be, a skin or eye as well. It's more broad. We know that a drug was taken. That's why it's not product, because it is a bit narrowed. It's medication. It's a drug. So the choice 1 and 3, you could sort of waver between it. But since it says medication, I'm going to go ahead and say it was a drug. Accidental drug intake by child is the correct answer. And exposure is broader, like I said, so it would not be exposure. Okay, so let's go to number 8. And 8, let me activate it for you. The only information we have is infection after surgery. Okay, so what would I say? Is it infection? Let's take everything that we have in a term that has everything that's reported. So it's saying infection after surgery. Okay, wow. Okay, so I think, Hannah, we can go home today because almost everyone at some point had the correct answer of post-operative infection. And that's exactly correct, because we can't assume it's a wound, right? Nowhere does, most probably it is, but my verbatim doesn't say wound, so I can't assume. All I know that after surgery, which is the word post-operative, there was an infection. So I know at one point 100% said that. So those of you who took a leap and went to wound, you can't make that jump and assume. For those of you who just said infection, you're correct, but since you have a more specific term and the information is provided that it's after surgery, the best bet would to say post-operative infection. So that is the correct choice. Let's move on to number 9. Any questions thus far?
We have a couple questions in the chat. Our first one asks if you could please clarify the proper coding in the situation where death is reported along with a special scenario or a procedure and no adverse event / adverse reaction is reported. For example, medication error occurred and a patient died, or a patient was pregnant and died. In all three, in the examples, would you code death separately as a term in addition to coding the special scenario?
So, okay, first we did go over this, but certainly you can go in the PTC and specifically read on, how to address death. But the main take home point is if death is the only reported thing in your reported verbatim, you code it. Otherwise, if death is reported along with other adverse events that happened, you don't code death because that is reported in the outcome field. You report death in the scenario we said sudden cardiac death. If there is a term with the word death that provides clinical significance, then you certainly would code that. Let me go in the browser and look up death and show you all the various terms that have types of death. Now, for example, accidental death, that provides information, right? Okay, oh, it was accidental. You would, if it's a type of death, right, not simply plain old death, you would code that death term. Otherwise, plain death is captured in the outcome field. As well, if it provides any clinical information, obviously, fetal death provides clinical information, intrauterine death provides information, the sudden cardiac death, that provided clinical information. So you have to use your medical knowledge, whether that particular description or qualifier of death is providing clinical significant information, you would code it. If it's a plain death, it's already captured in the outcome field, provides no significant clinical information, then you don't code it. It's a judgment call as well. You can go to the let's see what it is. Not concept descriptions, but the MedDRA documentation, and you would go to the how to use support documentation. Under the PTC, we open up the document that we're talking about today in detail, and I would go to my section on death. Here it is. How it has specifically, so I would, since if they come across this a lot in their reports, I would go for the purposes of time constraint that we have, you should read the various scenarios, death reported with adverse events, death as the only reported information, death terms that add important clinical information, and other patient outcomes. Okay, so I would review this section in detail, although we touched upon each of these in various coding examples. So it's a medical judgment in the end. Okay, so we were on our example number 9 in the poll EV. And then the rest of the questions, I think I want to make sure I get through these, and then we'll look at them, Hannah, at the end.
Perfect.
Okay, so let's go to number 9 in our poll EV. Okay, how about this one? Let me activate it for you. If the only thing that's reported is had MI, what would we do? And some of the physicians out there, you'll say, of course I know what that means. I mean, that's easy, what I would code. MI. Okay, so remember, we can't assume in MedDRA. We choose the closest reported verbatim string. And of course, overarching, all of the principle over coding is to use your medical judgment. And of course, refer to your PTC document if you don't remember how to approach a particular scenario. So in this case, MI can mean, we can't assume they're meaning myocardial infarction, although majority of time in medicine, that's what it refers to, but it can mean mitral insufficiency. It can mean mental illness. It can mean mesenteric ischemia. I can't, jump in and say what it means. Therefore, the best thing to use is unevaluable event, because I don't know if it's in a person. I don't even know what it stands for. So it's the broad unevaluable event that I would choose. I would not take a leap and say it means myocardial infarction or mitral incompetence. And MI, if you look in the browser, I just have to show this. I'm going to open up myocardial infarction just to show you. I'm going to open it up in the right click, go to browser, and open it up in the browser to show you all the LLTs underneath myocardial infarction. And I have, when I look at all the LLTs under myocardial infarction, at one point in time, MI was the LLT to mean the PT myocardial infarction. But we can't use this now because in the very beginning I told you we cannot use non-current LLTs. Those are the ones with the red box around them. At one point this was a good term in MedDRA, but now it has been made non-current and therefore cannot be used for coding purposes. It's non-current. Therefore, the best thing to use in our here, the answer would be unevaluable event. That is the correct answer. 80% of you got that right. And 15% MI is non-current, therefore we cannot use that for coding. Okay, so let's go on to number 10. What would you do in this scenario? And we did have a couple of examples. Hypernatremia, and for those of you who don't have handy your lab reference ranges, a normal serum sodium ranges from 135 to 145 milliequivalents per liter. So 135 to 145 is normal. A normal is 135 to 145. And this is saying 115, and the term is saying hyper, which means more. Hypernatremia, increased sodium. And we congratulate our participants because 90% are saying the correct answer, which is serum sodium abnormal. And the reason it's abnormal is because we have conflicting information, right? Primarily, I would try to query to get the reason for the conflicting information. If I'm unable to query, I'm unable to get any clarification or additional information, I would say it's abnormal because my hyper means more sodium and the lab value is showing me lower than the reference range. So the correct answer is serum sodium abnormal. Okay, so going on to number 11. Let me activate this. She accidentally missed the morning dose. Okay. So we have to take everything that the verbatim is telling us, take that into consideration when we choose a LLT. Okay, and we keep it as close match as possible. Okay, if it was something as accidental for the 1% who's choosing intentional, something can't be accidental and intentional. I mean to do it, or it was an accident. Okay, good. So it's accidental. So it's an error. It was my mistake. It was an error that I missed my dose. So missed dose in error is the correct answer. Missed dose kind of missed the accidental part of it. So it's not just plain missed dose. So the correct answer is missed dose in error. Okay, and why not temporary interruption of therapy? That term is mainly used in scenarios where through no intention or accident from the user part, it's because of there's some issue in the supply, it's not available due to various reasons, or they had to stop it because a person wanted to get a CT scan. So that's those scenarios where it was interrupted for medical reasons or there's supply chain issue. The medicine is not available to the patient. Okay, so the correct answer very clearly is the missed dose in error. Okay, so let's go to number 12. How about this one? This has a lot of information in it. Let me activate it. Read it carefully. This is sort of like a medication error type of scenario. The doctor made an error while prescribing a medication. The pharmacist noticed the error and did not dispense the drug. So he made a mistake. He made an error while prescribing a medication. And I'm very happy to see that the majority, 93 plus people, did the correct answer of intercepted. Very important that you all caught that. You intercepted, he noticed it, and he didn't dispense it. He intercepted it. Intercepted drug prescribing error. Very good. That is the correct answer. And for those of you who chose dispensing, there are different things in the chain of events. There is prescribing, there is dispensing of a drug, and there's administration of a drug. So in this case, it's not the dispensing. It wasn't dispensed. It was at the prescribing phase where there was an error. He prescribed in error, right? So it's the intercepted drug prescribing error. Excellent. This was a kind of a challenging one. Okay, how about this one? I'm going to activate it, number 13. Dose was taken below the minimum recommended dose in the product label. And remember, for one of these, we said unless it's explicitly stated, you can't code it. However, one of the things we looked up was the concept description. And if it matches the concept description, then you can say that particular scenario. Dose taken was below the minimum recommended dose in the product label. And okay, good, excellent. So I'm seeing again, thankfully, majority of my attendees are saying the correct answer, which is underdose, because the unique scenario where this is the concept description for underdose. Below a dose taken below the minimum recommended dose in the product label. So let me look up just to confirm for you all that underdose is described as such. Administration of less than the minimum recommended dose. So that is what is in our verbatim. Dose take below the minimum recommended dose, so I can safely say underdose. If in doubt, look at the MedDRA concept description. And we can't say error because we don't know if it was an error, if it was intentional. We really don't know that. Again, accidental, I don't know if it was accidental, right? And I think it's underdose. We can say it's incorrect dosage, yes, but more precisely, it's an underdose. So that's the correct answer. Okay, number 14. This is important. Let me activate this. This is, again, going to be correct by those of you who are familiar with how the hierarchy works, and you check the hierarchy. Abused by her husband. How do I capture that? This is a very tricky one. My more advanced MedDRA coders will get this, or those who have been listening very intently to all the pearls of wisdom that I have been sharing. Here, this is a very prime example of checking the hierarchy of the term. Okay, so before people keep shifting, and the correct answer is, again, with the majority of my class, 85% said victim of spousal abuse. But let me tell you why. So let's go one by one. Abused by her husband. So this is a lady that's abused by her husband, right? So physical abuse. There are different types of abuse. There's emotional abuse, there's physical abuse, there's, these are the two types. We don't know if it was physical. It doesn't say, right? Battered wife. We don't know again if it was a physical abuse. Spousal abuse. Let me see what 14% of you said spousal abuse. Let's see in our hierarchy where that goes. Okay, so if we look at spousal abuse, we look at the hierarchy, goes to PT spousal abuse, but it's going to the HLT criminal activity. So when you choose this term, it means you are the perpetrator of the abuse. That person is doing the abuse. He is the abuser, right? Spousal abuser also goes to the same PT, spousal abuse. So spousal abuse, spousal abuser means they are the people doing the crime. Whereas victim of spousal abuse, which is the correct answer, goes to the HLT crime victims and not the HLT of criminal activity. They are the victims. So important to look, it's very tricky, but you can confirm that you're making the correct choice LLT term by looking at the hierarchy. And here it was very important to look at the hierarchy because it could be a bit tricky. So that's why you wouldn't use spousal abuse, because this is reporting someone who's being abused by the husband. So it's the victim. Okay, so let's go to number 15. We're almost towards the end. And I'm going to activate this. The patient was treated with drug Z for rosacea. Let me see if this is more clear here. Yeah. So here, the patient was treated with drug Z for rosacea, which is an off-label use of this medication. Unfortunately, she developed severe dizziness. A lot of stuff in here. So which string has all the things that you should code? So one of the strings is you should code rosacea and dizziness. The other choice is you should code off-label use and dizziness. The third choice is you should choose off-label use in unapproved indication. And the third choice is rosacea, off-label use, and dizziness. So which is the correct choice? Okay. Let me go. Okay, so the correct choice, which the majority of you chose, was rosacea, off-label use in unapproved indication, as well as dizziness. So all three is the correct choice. So the next popular answer, which is off-label use and dizziness, in addition to showing you off-label use, it shows you what the off-label use specifically was for, right? He was treated with drug Z for rosacea, and they're showing you that using the drug for treating rosacea is off-label use of this medication. So it's not typically indicated for rosacea, and they're telling you it's treated for rosacea, but this is off-label use of this medication. So you can say off-label use in unimproved indication. It's telling you that information. And then, of course, you also code what happened. The indication, rosacea, and what happened? He got dizziness. So all three things, the indication, the specific off-label use, and the dizziness should be coded. That is the correct answer, the last one, which 68% of you used. Okay, and of course the term selection document tells you that when medical condition or indication is reported with off-label use, and an adverse event occurs, the preferred option is to select LLTs for the condition, the indication, as well as the specific off-label use. And we took the preferred approach, and the third one is the correct choice. Of course, you also have the alternate choices, the alternate option to code, but the preferred option is the last choice. Okay, so this was a very long one. So the very last one for our coding exercises today is a 27-year-old woman took a 2-week course of antibiotics during her pregnancy. She did not experience any side effects. Let me activate this. So what would be the best of these three choices? So you can pick one of which one LLT is the best LLT. Okay, so here, let people work on it a little bit. Okay. Okay, so the best choice for this one is majority of my respondents, 85% are correct. The correct choice is maternal exposure during pregnancy. Now, of course, you could, in the alternate approach, also code that and no adverse effect, but our preferred approach that we've been looking at, as well as in the PTC document, is not to code absence of an adverse effect, right? And of course, you can't choose normal pregnancy because we don't know. I mean, we didn't go all the way. She didn't experience any side effect right now, but we don't know what happened towards the end of her pregnancy. There's no information. Right now, she's not experiencing any side effects, but we don't know how the outcome of the pregnancy was. So that's a stretch. The thing that for sure is reported is that she did take some sort of drug during the pregnancy. So there was maternal exposure during pregnancy, and that is the correct answer. So excellent job, Hannah. You can confirm that all of the exercises, the majority of the attendees answered correctly. So excellent job, everyone. It was like 85 plus always had the correct answer. In some places I saw 99 and 100. So let's go back to our presentation. And then we can, after doing the concluding remarks, we can then go to take questions. So we have done the exercises, and let's see. I think this is where we'll go. Okay, so again, we did do this in several of the examples. I just want to take home the message that in MedDRA, MedDRA has terms to code more than just adverse events, right? Because MedDRA is used to code terms in the indication field. It's used to code terms in the outcome field. And just looking at this little narrative, a 75-year-old male receiving drug X for rheumatoid arthritis, you would code that because that's an indication. That's what he took the drug for. You would also code develop symptomatic aortic valve stenosis. That's some adverse event. So you could use MedDRA to code specifically aortic valve stenosis. The patient's medical history is significant for colon cancer and cigarette smoking. Again, MedDRA can be used for coding a medical history, which is colon cancer and cigarette smoking in this case. And then, of course, he underwent an aortic valve replacement, which is a surgical medical procedure. We have lots and lots of terms in MedDRA for various surgical procedures, and developed a sternal wound infection 3 days post-surgery. We have lots and lots of terms, as you saw in one of our previous coding examples, for post-surgical complications. In this case, it's a wound infection, post-surgical wound infection. So just to show you that MedDRA can be utilized for more than adverse events, it can be utilized for indications, it can be utilized for outcome and medical history. Okay. Again, Always try, these are some of the wisdoms or the coding pearls that we sort of focused on today. You should have learned to always use the exact reported verbatim as close as possible. Be aware that MedDRA is very granular. Like I said, over 90,000 plus LLTs in this version. It's very specific, so that maybe there's a term that matches exactly what's reported. Look at MedDRA hierarchy. Remember, for that term, we were more clear of why something was a congenital term versus an acquired term. If an LLT is close to what you need, look at its other PTs and look at other LLTs in there. And check whether the LLT lies in the correct hierarchy that you want. Do you want a congenital term or not? That'll make it clear for you. As well, sometimes you're not sure if a particular term is in MedDRA, so use the top-down approach. Look at the SOC and continue drilling down lower and lower in the hierarchy to see if you find the term you want, or vice versa. Go to do a bottom-up search, look for an exact term, and then look at other PTs. Maybe that's a better match. Again, someone asked these very nice, important questions. Do you make use of your resources if there's something difficult that you don't understand? Like someone said, what if we don't know the gold standard signs and symptoms of a particular disease or disorder? By all means, use all the good, valid medical references, use the good, valid medical dictionaries, and other specialists who may have more experience than you. Again, the MedDRA browser allows you to use very advanced Boolean searches like the percentage sign if you only know a partial of a word. So it has very advanced search features. And of course, become familiar. We went several times today and looked at various MedDRA concepts. Use the browser and look at the various MedDRA concept descriptions if you're not sure how that concept is being utilized within the context of MedDRA. And of course, there are other training courses. We have a MedDRA Coding Basics class, which is typically advised to be taken before this class. As well, we have more webinars on other topics, like I told you, on medication errors. If you want to do a deeper dive on medication error terms, how to capture various MedDRA error concepts. And of course, we have webinars solely dedicated to SMQs, as well as webinars on data analysis and query building. And I would like to advertise that next week we are doing a Let's Code Together training next week on March 11th at 11 a.m. Eastern Time. So if you'd like to get your hands on more how to do coding, we present various coding scenarios and we discuss how one person would approach it versus another. It's an hour-and-a-half long session. So if you're interested, please remember to join in. Check your MedDRA website for the exact timing. Okay, so in summary, we looked at various principles in the MedDRA term selection points to consider document. We showed you MedDRA concept descriptions. Of course, we discussed and we actually performed very well, I might say. Most of you got the right answers. We used the browser, we used Pull EV just to test your knowledge. And of course, we are very familiar now with some of the coding wisdom pearls. Here you have access to these slides. These are all website address for our website. Email how to write questions to the help desk, mssohelp@meddra.org, as well as various links to our desktop and web-based browser, and some of you even use the mobile browser. So all of these links are there for you to access from the available presentation. Here is a link to how to submit a change request. If even these 90,000 plus LLT terms, you still see a concept that you think could be useful in MedDRA and is missing, by all means, you are very welcome to submit a change request for us to add a term at any level of the MedDRA hierarchy. So you can do that. And of course, for more trainings, look at our training schedule. Here's a link how to access that from our website. And of course, several times I showed you how to access the MedDRA support documentation, both from the browser as well as the meddra.org website. So now I think it's a good time to have our Q&A. Anything that I missed?
Wonderful. We did have a follow-up from the question about death. They said The sections that were referred to either describe a scenario when death is reported together with an adverse event or adverse reaction, or death is the only available information. What would your opinion be on coding of death reported with the special scenario or procedure when no adverse event or adverse reaction is reported?
Yes, I would recommend if no other adverse event, adverse reaction is reported, and that's giving you clinical significance, I would then code it. And in fact, even if some adverse event is reported, but that type of death is giving you some clinical hint or information, I would code it.
Great. Our next question asks, is the coding good enough as long as we come to the same PT, even if the LLT is not quite correct? I am asking because of the deliberate overdose versus intentional overdose example.
Okay, let me show you. Well, at sometimes it doesn't really make a difference. Other times it's better to be more precise. So let's see, deliberate overdose. Okay, so deliberate overdose, the PT is intentional overdose. So in this case, if you use intentional overdose or deliberate overdose, it's one and the same thing. Absolutely right, because it's just a synonym. But the take-home message was to be as exact match to LLT, verbatim LLT as possible. But technically speaking, you would not be wrong because you are not subtracting or adding information. You're just using a synonym, deliberate for intentional. So yes, you would be perfectly fine. Any other questions?
Our next question was about an example. The child was exposed to mother's medication, so shouldn't it be accidental exposure to product by child since it was not the child's medication?
Let's go to that example. So I think that was a poll question. Let's see. The child example was, okay. So the reason we didn't do exposure, because exposure is broader than drug intake, right? He took, the verbatim tells us he accidentally took his mother's medication. So there was drug intake by the child. Accidental exposure to product by, let's see, what is that? Accidental exposure to product by child. This is more broad. As I said, exposure term in MedDRA can mean exposure to skin, exposure to the eye, right? It's very broader. Here, this is more precise as to what actually happened. He took drug intake. So I wouldn't use exposure because it could mean many different things. Okay. Anything else?
Right. Our next question is a bit long. It says, could you please clarify the proper coding for events reported as post-mortem? For instance, a literature report discusses the post-mortem report of the subject and the analysis detected elevated levels, poisoning from the combined use of drugs. Do you code drug poisoning? Or would we also need to code a drug interaction event to cover reported combined use of both drugs?
So from that long question, what I can gather is if something, some event is given or described, but it's a post-mortem finding, I would also code. Remember, sometimes you use two codes to make clear and you know, to convey a more clear message. I would use either of, depending on the scenario, if something was found increased, decreased, or whatever, I would use in addition post-mortem blood drug level abnormal or increased or decreased depending on the scenario. So this would give in additional information that this is a post-mortem finding. So we have that post-mortem in here.
Our next question asks, what's the difference between blindness color and color blindness? And in general, the difference between LLTs that differ only from the order of the words?
Color blindness. So that one, that again, it goes to the same PT. It's splitting hairs. Technically, you would be absolutely correct with saying color blindness or blindness color. It's one and the same thing. And as far as the spelling, as you know, at
Amina, your audio's gone out.
British spelling option is at PT level, and the American English option is LLT level. The only thing we were trying to emphasize was trying to do exact match, but technically the word order or the spelling of British English does not matter. You would be absolutely correct either way. To say color blindness, blindness, color, it's one and the same.
All right, our next question asks, just to confirm my understanding based on your example on slide 41, we should not code drug interactions unless they are explicitly mentioned in the report, even if the medications, drug, or food involved are known to interact. Is that correct?
That's very correct. I don't know what the numbering is now of drug interactions. Okay, so yes. So only if the reporter does not specifically state an interaction, you don't say interaction. Like here in our example, the patient drank cranberry juice, so this is very important, which interacted with the anticoagulant drug. That's the only reason I could say food interaction, because they stated which interacted. If it just said patient drank cranberry juice, he took his anticoagulant drug. This caused an INR increase. You could assume if there was an interaction, but it doesn't say, then you cannot say interaction unless it's explicitly written. So they're right. Unless it states there was some sort of interaction, you can't assume.
All right, our next question says, regarding the MI example, what about a situation where there would be symptoms of myocardial infarction listed and diagnosis would be stated as MI? Could you assume that it's myocardial infarction?
You should not assume, but again, we also said that if your report gives you, some medical, clinical, contextual information, right? And remember we said use your medical judgment. If there's enough medical contextual information that is making your medical judgment say, of course it's a myocardial infarction because of other additional information, then you can make that leap. If there's enough other contextual information leading you to believe so.
All right, our next question says, how would you approach in a physician's report hyponatremia or hyponatremia with a normal value?
If it said hyponatremia or hypernatremia with a normal value, of course that's conflicting because neither is it high, neither is it low. The lab value, if it's in the normal reference range, but the other word is either a low or a high, then it would be vague, and then you would do the abnormal code.
Fantastic. Our next question says, why in question number 15, I believe in the polling, why in question number 15 is the correct answer off-label use for unapproved medication, since it's not explicitly noted that the medication is not approved?
1 second, 15. Okay. The patient was treated with drug Z for rosacea, and so he's treated for this disease, rosacea, which is an off-label use of this medication. So off-label means that typically this drug Z is used for another disease, to treat another disease, another indication. But here it's being treated for rosacea, a disease for which this is an off-label use of this medication. So the indication rosacea is off-label. So you can make that decision that this is off-label use in unapproved indication. That's what off-label is. Off-label can be for different scenarios. Let me just show you. The term off-label, things can be off-label for so many different things, right? So let me just show. The PT off-label, when I open it in the browser, has many LLT. Off-label means, so basically, let me see again. Let me show you for clarity. Okay, So in our MedDRA concept description, right, off-label use relates to situations where a healthcare professional intentionally prescribes, dispenses, or recommends a product for a medical purpose not in accordance with the authorized product information. When recording off-label use, consider that product information or regulations requirements may differ between regulatory regions. So the authorized product information, for example, I'm taking a drug that's used to treat disease A, right? And it's recommended to take 50 milligrams for adults for this disease A. If the doctor, healthcare professional, prescribes it for another disease B, right? And in a child, even though this drug in the label is only approved by the regulators for a certain age group, for a certain dosage amount, for a certain disease, but the doctor does so otherwise than what's in the label, it's considered off-label. Okay, now off-label can be for of the dosing amount. Maybe it says only use 50, and he's saying, no, I want you to take 100. Or it can be for a different age group, unapproved age group. It can be for unapproved indication. It can be for unapproved route. Maybe, instead of, maybe it was for IM, intramuscular use, he's giving IV. Just as an example, I'm telling you. So it can be unapproved route of administration. It can be an unapproved sex. Maybe it's only for females, but a male is, the doctor says for a male to take it. So there's different scenarios and different aspects of the label that it can be used off-label, right? And so in our scenario, it was for indication because typically it's used for drug. Z is used for something else, but the doctor used it for rosacea. The patient was treated with it for rosacea, which is an off-label use of this medication. So it's a different indication. That's why we can say unapproved indication. So I hope that's clear because there's different scenarios it could be off-label.
Someone has sent a follow-up about this example saying, so why capture rosacea if it is the indication for the drug use?
Actually, it's very important to capture rosacea because the PTC, when you go look at it in more detail, it says when in scenarios where something is used off-label, try to capture whatever. So it's used for rosacea. This is the indication. So important to capture rosacea. That's what the PTC guide says.
Wonderful. Our next question asks, can you use cranial nerve numbers and names interchangeably?
Okay, well, let's see what our MedDRA does. So cranial nerve. Let's see if there's a number. I typically think, okay, so 8th cranial nerve lesion. So see, in the PT for 8th cranial nerve lesion is the number 5, the Roman numeral nerve lesion. Let me look up 8th nerve. One second. Where did it go? There it is. Okay. So if we look at 8th nerve injury, it has the name as the LLT. So in this case, it says 8th nerve, the number, 8th nerve injury, and it says vestibular nerve damage. So it named the nerve, but the number is at PT level, the name of the nerve is at LLT level. So you could check, use your browser to check. Here it says, as another example, cranial nerve, 3rd nerve paralysis, and it goes to PT, the numerical number, 3rd nerve paralysis. And if I open up that PT, let me see all the LLTs under there. And as you know, the 3rd nerve, that's the one I exactly remember, is oculomotor. So it does go by the nerve name as LLT. So there's your mystery solved. It goes by number at PT level, and it goes by the nerve name at LLT level. Okay, I hope that answer was adequately answered. That question was answered.
Okay, it looks like we have just 2 final questions.
Okay.
In the analysis, how can we distinguish rosacea as a wrong indication with rosacea as an adverse event?
That would have to be, you would have to read your report in context, and that's why when you would have the term off-label use and unapproved indication, you would read the report in its entirety and figure out that this is the unapproved indication is rosacea. You don't have to read the report to get the contextual, clarity. Second question.
All right. Our last question asks, but for off-label, the doctor has to prescribe it intentionally differently than it is in the SMPC, right? What if I don't know if it was intentional or if the doctor thought AG
Okay,
indication was mentioned in SMPC?
very good. Excellent question. So usually you can't use off-label. So this is something that I'm going to be very careful to say. So before, you are not able to say off-label use unless it's explicitly stated. So that unless something is specifically stated, here we can say off-label because it's written in our verbatim, which is an off-label use. It's explicitly stated, that's why I can say off-label. But let me go here. One second. Okay, so you see that in version 29.0, because of user input, it's a very excellent question. I'm very glad they brought it up. Before, no matter what the report said, if it didn't say the words explicitly off-label, you were not allowed to quote off-label, even though the whole scenario made you think, of course it's off-label. But unless it said off-label, you couldn't do it. Now, due to user input and lots of discussion, we have added a term, suspected off-label use. So this is to address scenarios where the report doesn't say specifically off-label, but the whole scenario describes it, and you most probably think, I think it was used off-label. Then you use the term suspected off-label use when it's not explicitly stated in the report off-label. So now we have that for you in 29.0, suspected off-label use. It's a good question. I think that was our final question, right?
Yes, it looks like that's it for us.
Excellent. Well, thank you, everyone. Really appreciated your very, very excellent questions. Means you were really paying attention. And thank you so much for excellent performance on your poll EV questions. I hope you learned a lot today. Join us next time. And for those of you who are interested in learning to code even further, join us next week on March 11th on our Let's Code Together webinar, which starts at 11 a.m. Eastern Time. So have a wonderful week. Thank you.